Hey, everybody, welcome to Perspectives in Primary Care, this special edition in honor of the dearly departed Chadwick Boseman. I am Dr. Kadisha, your board certified emergency medicine physician, here with Dr. Carol. Introduce yourself.
Hello, I'm Dr. Carol Penn, your doubly board certified family medicine and obesity medicine specialist, also your master movement meditation and mindset coach and two-time best-selling author, podcaster, blogger, and here to talk to you about someone very special and also about a disease that we need to have more education and awareness about.
And Dr.
Yes, and I am Dr. Dietrich Gorman, a board certified family medicine physician, and I'm America's relaxation doctor, best-selling author, and consultant. So thank you very much for joining us this evening. We're coming here tonight to talk about a serious issue, but also to bring education and then pay homage to the dearly departed Chadwick.
Okay, so ladies, just a quick intro or discussion about the late great Mr. Boseman's life. He was born November 29th, 1977 in Anderson, South Carolina. He attended Howard University in Washington, D.C., where he studied the fine arts and actually began his early career acting, teaching, writing, and all that in New York City, and relocated to Los Angeles for his first leading role as Jackie Robinson in the film 42. Of course, we know about the other films, Black Panther, James Brown's Get On Up. But at this point, I want to talk about the times during which he was a real life superhero. And there was a great article in Variety magazine where they discussed 5 different occasions during which he was a real life superhero. So, yeah, not only was he the lead of the first predominantly black cast in a Marvel film, but he had done some other things that made him a superhero. One was visiting children at St. Luke's Children's Research Hospital in Memphis, Tennessee, 2 years after his own cancer diagnosis in 2016. He was diagnosed with stage 3 colon cancer in 2016 and made visits to children at that hospital. Another thing that he did, the second thing that he did was to he gave an encouraging graduation speech at Howard University for the 2018 graduating class, where he congratulated the students on protesting what they believed in and told them the story of how he met Muhammad Ali on campus, and also shared some of his experiences with rejection during his acting career. Another thing that he had done was after filming Black Panther, he appeared on The Tonight Show with Jimmy Fallon to participate in a segment during which he actually surprised fans of the film. Children, more work with children. Mm-hmm. And another thing that he did was he gave a very heartwarming speech to honor Denzel Washington, who I guess it was fate. Denzel Washington ended up paying his tuition for his summer at a British acting academy at Oxford during his years at Howard. He had said that Felicia Rashad had reached out to various actors to help sponsor 9 acting students to go to this summer acting program at Oxford. And Denzel Washington actually privately, and he said gracefully, agreed to contribute. And when Denzel Washington was being honored, he actually teared up when Boseman told of the impact that Denzel Washington had not only on his own career but those of many other Black actors, and told him there is no Black Panther without Denzel Washington. And lastly, after he won the Best Hero Award at the June 2018 MTV Movie and TV Awards, he chose to honor another hero with his trophy. He honored James Shaw Jr., who just a few months earlier had saved lives during a shooting at a Waffle House in Tennessee. If you remember the gentleman who, who stepped up and put the shooting to an end at that Waffle House just about 2 years ago. So to that end, we wanted to do this discussion on colon cancer because, a man who was taken away this soon cannot die in vain. Yes, he left a great impact, but we also want to learn a lesson from him, one of many that he left behind. But this lesson also, I know he would want us to take a lesson from this as well. So that's our discussion on colon cancer, and we will start with Dr. Dietrich.
Oh, okay. So just so I can kind of add on to what Dr. Kadisha was saying, one of the ways that I was so impressed by Mr. Boseman was in the movie, the iconic movie Black Panther, as well as his role in the Avengers, because I'm a big Avengers fan. And for me, I mean, Black Panther was just like a great movie for so many reasons. And it meant so much to so many different people. And one of it was that it really portrayed mostly young Black folks in positive images, saving the world, being high, good role models, and using the best technology. I mean, and also designing that technology. And this movie had grace, humor, action, culture, romance, and it was just so transformational. And it was such a symbol that we don't have to be in these stereotypical roles. We can save the world, we can use the highest technology, and we can just really do our thing and we can thrive. And I really feel that that's what this movie did and what he did for us. And I'll never forget it. Yes.
Oh, wow. Wow.
Hey, what are your thoughts, Dr. Carol?
All right. Well, I'm just sitting here and I'm listening to both of you, and I'm reflecting. I know that Black Panther had a tremendous impact on me. I was around Wakanda forever for weeks after that. Because we don't often see African Americans portrayed as the superheroes. And the fact that this movie made more money than any other Hollywood film, like in the history, also show that there was big box market for it. That's often been an argument that Hollywood has used to say, well, we don't want to make Black movies because Black movies or movies with Black characters don't make enough money. And it's not true. This is something that had universal appeal to the world, with themes of heroism and love and courage and heart are themes that all of humanity relates to. So for that, I have so much gratitude for him. He played King T'Challa to the max. He was brilliant in the role. And then, of course, his roles as Thurgood Marshall, as Jackie Robinson, and as James Brown. Brilliant. Oh,
iconic, yes.
Yes, iconic roles that brought to life aspects of African American history that the world needs to know, because it's history that has its place in the history of humanity. And so I felt that he understood his purpose in life, that he was very authentic. He had a lot of integrity. And also, being diagnosed with stage 3 colon cancer. Everybody would have understood if he didn't make any movies, if he kind of dropped out and just wanted to, take care of himself. But instead, he stood in the center of the purpose of his life, and the world got to benefit from it. And I think that's the take home lesson about knowing your purpose in life and walking in your purpose. And I'm so grateful that he demonstrated that.
Well stated, yes.
So everyone, so now that we have shared a bit of why we're doing this broadcast, we want to get into the lesson. Now that we've discussed the legacy, we're going to discuss the lesson that we can all take away from this as far as our own safety and our own health with a discussion of colon cancer, starting with Dr. Dietrich.
Yes. And just real quick before I get started, thank you everybody for tuning in. Victoria, Kasali, and Dr. Ken, we really appreciate y'all joining us. And yeah, I'll get started. So I'm going to actually start off with, in general terms, what is cancer, what is colon cancer, the types of colon cancer, and some stats. All right. Exactly, Dr. Ken. Let's not forget the impact on his spouse. Absolutely, absolutely.
Definitely.
Okay, so just in a general definition, for those of you who don't know the exact definition, what is cancer? I mean, we've heard about it. The word, when we hear the word, a lot of the times we get scared, we shudder. We think it's a necessarily just that's it with life, but it doesn't necessarily have to be. I mean, unfortunately, it was in this case, but what cancer is basically the uncontrolled growth of abnormal cells in the body. And cancer actually develops when the normal control mechanisms they stop working, and old cells don't die off. Instead, they grow, and they grow abnormally, and they keep growing, and they grow new cells that are abnormal. Okay, and the actual branch of medicine that is dedicated to diagnosing, treating, and researching cancer is known as oncology. And the type of doctor that deals with that is called an oncologist. So, what is colon cancer? It's cancer of the colon. And you may have heard the term rectal cancer, colon cancer, colorectal cancer. You just may not be totally clear on this, but I'll just clear it up just a little bit because it is a little bit different. The colon and the rectum are both part of the large intestines, which is sometimes called the bowel. And cancers of both organs are grouped together as colorectal cancer. Now, I'm not exactly sure which part or which type of cancer he had, but for public sake, it's just colon cancer. So the colon is actually the first 5 feet of the large intestine, and it absorbs water from the stool. And the rectum is the last 6 inches of the large intestine, and it's where the body stores the stool until it's time for you to have a bowel movement. And the rectum is like a tighter space. It's close to your urinary bladder, as well as the vagina for women and the prostate for men. So it's kind of real close to each other. And that may actually affect the kind of treatment that doctors do if a person is diagnosed with colon cancer. And actually, there's really not a single cause of colon cancer. Now I'm going to just transition into some of the colon cancer stats. And not counting for some types of skin cancer, colorectal cancer is actually the third leading cause of cancer-related deaths in the United States. It's the third most common cancer in men and women. And the American Cancer Society's estimates for the number of colorectal cancer cases in the U.S. for 2020 are 104,000 new cases of colon cancer. This one is from the American Cancer Society. The rate at which people are diagnosed with colorectal cancer in the U.S. is dropping among ages 65 and older, but rising in younger age groups, according to this American Cancer Society. And in 2020, 12% of colorectal cancer cases will be diagnosed in people under the age of 50. So that's about 18,000 cases, which is quite a lot. Rates have been increasing since the mid 1980s in adults ages 22 through 39. And since the mid 90s in adult ages 40 to 54, with younger age groups experiencing the steepest increase. And during the past 20 years, the rates of colorectal cancer fell in people ages 50 and older, largely because of the recommended screening test. And Dr. Keller is going to be going over that. So all in all, the lifetime risk of colorectal cancer, the overall lifetime risk of developing it is about 1 in 23 for men and 1 in 25 for women. Now, briefly, there's different types of colon cancer. Adenocarcinoma is one of them, and that's actually the vast majority of colorectal cancers. And adenocarcinoma is a type of cancer that actually starts in the cells that make up the mucous membranes in the intestines, and that's what lubricates the inside of the colon. So you have a bunch of mucus cells that helps stool pass, and this is actually where most cancers start. And they usually start by being what's called a polyp. So you might have heard that term before. Then you have a carcinoid tumor, which is a hormone-producing tumor, gastrointestinal stromal tumors, and then lymphomas. And then there's also hereditary colon cancers. So about 5 to 10% of people get colorectal cancers because of specific mutations in the genes. So that's one of the types of colon cancers. Now, here's a big one. What are some of the risk factors for colorectal cancer? But first, what is a risk factor? You may have heard that term, but you don't know exactly what it is. And so from freedictionary.com, a risk factor is actually a characteristic or a type of condition or a behavior that will actually increase the possibility of acquiring a particular disease. So in reference to colon cancer, there's actually two types of risk factors categories. There's a non-modifiable and then a modifiable. What does non-modifiable mean? Non-modifiable. Basically, it means there's nothing you can do about it. It is what it is. All right. You just can't do nothing about it. And one of the things that are non-modifiable is your family history, your genetics. There's some inherited disorders that predispose you to acquiring colon cancer, and that's just how it is. The second non-modifiable is your age. Just keep on living. Over the age of 50, you are at an increased risk. Your ethnicity. African Americans and Jewish people of Eastern European descent have a higher risk. And actually, African Americans have the highest death rate and the shortest survival of any racial and ethnic group in the US for most cancers. Diabetes. This is kind of somewhat modifiable or non-modifiable depending on how you look at it. So that's another risk factor. And then if you already have these colon issues, inflammatory bowel disease like Crohn's disease, or if you've already had polyps, or ulcerative colitis, so you're at an increased risk factor if you've had these issues already. And then being a man, men have just a slightly increased risk of developing colon cancer than women do. And then finally, if you've had any type of radiation treatment that's directed at the abdomen and treating other previous cancers, your risk can increase with that. And so I guess that can be kind of a modifiable one, but if there's no other options to be treated for that, then it becomes more of a non-modifiable. Now, some of the modifiable risk factors include some of the basics, your lifestyles, right? The use of alcohol and tobacco, this increases your risk. Lack of physical exercise or being physically inactive. Not eating your fruits and vegetables or having a lower fiber diet. You're not keeping that stool moving. Higher diets in red meat and processed meats. Those chemicals and carcinogens that are in those processed meats. Being overweight or obese. Having diabetes. And then also an interesting thing I found is having low vitamin D levels. From the vitamincouncil.org, many studies have shown that there's a link between vitamin D and colorectal cancer. And people who have low levels of vitamin D are more likely to develop colorectal cancers. And researchers are actually still trying to find out why. And then on the same line at cancer.org, the lowest colorectal cancer risks were found in people who had circulating vitamin D levels, who had low circulating vitamin D levels than that's recommended for the sufficient concentrations. But the risk did not continue to decrease if you had really, really high vitamin D levels. So that was a very interesting study. Now, what do you need to look out for? What happened if you possibly have colon cancer? How would I be diagnosed? What are some of the symptoms? What goes into that? And these are great great questions. And Dr. Khadijah are going to talk about these answers. What are the symptoms? How do we diagnose it? And what are some of the stages that come along with this diagnosis? So Dr. Khadijah, take it away.
Thanks a lot, Dr. Dietrich. And I apologize in advance for some page turning because it is a lot. But I will say that as Dr. Dietrich so well put it, the colon cancer starts with small, non-cancerous polyps that produce few, if any, symptoms, which is why regular screening tests are advised for prevention, which Dr. Carroll will discuss, to remove such polyps before they turn into cancer. But once the cancer develops, it may still take some time before symptoms develop. Mr. Boseman's cancer was not diagnosed until it was at stage 3. And that's not uncommon. So that's another part of the lesson for us, that, you might not develop any symptoms until it's well advanced. So what determines the symptoms, though, once you start to have them, or once one starts to have them? Well, those symptoms are often determined by the cancer size and location. And symptoms could include persistent changes in bowel habits, such as diarrhea, like persistent diarrhea, persistent constipation, or even a change in the consistency of the stool, such as a narrowing of the caliber. So, like maybe a much narrower aspect to your stool lasting for multiple days. Another symptom includes rectal bleeding, and you might see blood on the stool, or blood mixed in the stool, or an actual change in color, like to a darkening or a blackening of the stool. Now, even if you don't have that, you might just have some persistent abdominal discomfort, such as cramps, pain, or gas, or a feeling that your bowels are never empty. That feeling that you need to have a bowel movement, that feeling that isn't relieved by actually having a bowel movement. And the cancer causes the bleeding because it actually bleeds into the digestive tract, causing, after enough blood loss, weakness or fatigue, or unexplained weight loss, often due to anemia. And sometimes anemia is the first sign of the cancer.
Mm-hmm.
Other unexpected first signs of the cancer include an enlarged liver, jaundice, meaning yellowing of the skin or yellowing of the whites of the eyes due to spread of the colon cancer to the liver. Or you might have trouble breathing, a very unusual symptom, it would seem, of colon cancer, but colon cancer often spreads to the lungs as well. So you might present with unexplained shortness of breath. And then other things that might be, that it might be instead of colon cancer, because, in the ER, we always have to consider a number of different possibilities. So, if you have any of these symptoms, don't automatically think you have colon cancer. There are other possible symptoms, such as irritable bowel syndrome, various infections like diverticulitis, which is another, like an inflammation of the colon, outpouchings of the colon, or it could be hemorrhoids. So once someone comes and presenting with persistent symptoms like this, we start with a number of things to get you on the road to diagnosis. And it could be the basic blood tests, starting with the, your medical history, physical exam, things like that, because we want to hear about, we're going to look for those risk factors that Dr. Dietrich was talking about. And we're going to ask about your family history. Sometimes your family history, if you have a history of this, can let us know that colon cancer is something that needs to be brought to the forefront, or, at least closer to the top of the list. And we're going to ask you how long you've had the symptoms, when they started, things like that. We're going to examine you. We're going to, feel your abdomen. And unfortunately, but be prepared, we might have to do a digital rectal exam, meaning we'll need to insert a gloved, lubricated finger into the rectal area to feel for any masses or other abnormal areas. Another thing that might be done, and this is typically done by your primary care physician, is occult blood testing of the stool, where your doctor may recommend a stool test to check for blood that isn't visible to the naked eye. Thus the word occult. It's not visible to the naked eye. You get a card with 3 little panels on it for you to provide samples of 3 different bowel movements that will be sent to a lab for testing. And they might get blood tests. So, we might check, either I or your primary care physician might check for a complete blood cell count, which checks the number of white blood cells or red blood cells to evaluate for infection or anemia. They might check liver function tests to check for elevated liver enzymes as a sign of spread to the liver. And then most specific is the CEA test, and that's the carcinoembryonic antigen, which helps with the diagnosis of cancer. And in people who are already diagnosed with cancer, it can also monitor the progression or regression of such a cancer. And I'll try to go quickly through the rest of this. So after the blood work and the stool test, there's the imaging. And, the main thing that we know about is the diagnostic colonoscopy, where the entire length of the colon and the rectum is examined with a colonoscope, or that you might have a proctoscopy done, meaning a rigid lighted tube might just evaluate the rectum. And during either of those, colonoscopy or proctoscopy, you might have a biopsy done where a sample of a polyp or other suspicious lesion is taken and sent to the lab. And what they're looking for at the lab is, of course, whether or not it's cancer. And then also, if it is cancer, they want to classify it to see what the best treatment option is. They might even do gene testing because the various genetic makeup can help determine what drugs might be helpful. Other tests that are good to look for colon cancer, and they might be done beforehand, is a CAT scan. The CAT scan might be done by us in the emergency room. That can be done, within minutes, and it helps to tell if colorectal cancer has spread to nearby lymph nodes, to your liver, lungs, or other organs. So the CAT scan is great to check for a metastasis, otherwise known as spread. And then there might also be a CAT scan guided needle biopsy. And you'll probably ask about other tests, because I know people don't want to get colonoscopies, and that's another reason why colorectal cancer is so common, because a lot of people don't want anything in their colon or their rectum. And you might ask about an ultrasound. Abdominal ultrasounds they're good for checking tumors in the liver, gallbladder, or pancreas, but they're not ideal for the colon or the rectum. That there might be the option of an endorectal ultrasound, where a special transducer is placed in the rectum to check the rectal wall, but that's usually not going to be like the only kind of imaging you're going to get. Like you're still, we still cannot likely get around getting a colonoscopy done. An MRI might be done as well. The PET scans, a lot of people who've had relatives or who have personally had experiences with cancer might ask about the PET scan, where a slightly radioactive form of sugar is injected to the blood and collects mainly in cancer cells. These PET scans aren't routinely done in people with colorectal cancer. CT scans and MRIs are typically done more often. Okay, so once the diagnosis is made, then we go into the staging. And According to the American Cancer Society, the stage is determined by 3 different characteristics. One is the extent or the size of the tumor, and it's and they call it the T characteristic of the tumor. How far has it gone into the wall of the colon or the rectum? The second characteristic is the N. Has the lesion spread to nearby lymph nodes? Has the cancer spread there? That's the N. And then the third characteristic is the M, and that is whether or not there has been metastasis or spread to distant lymph nodes or distant organs such as the liver or lungs. And again, as Dr. Carol is going to discuss about screening, she's going to go into why screening is so important because, as I said before, Chadwick Boseman's cancer was not diagnosed until he was stage 3. So I'll step back for Dr. Carol.
Great information. Unmute Dr. Carol.
There we go. So unmuted, and this has been wonderful information, and I hope people are taking notes. I hope they'll replay this because, perhaps Chadwick Boseman's, we don't know the history, we don't know the story. Perhaps it could have been prevented, perhaps not. But the point being, this is the 3rd leading cause of death. And the good news is it is preventable if caught early. Colon cancers tend to be extremely slow growing. So in Chadwick Boseman's case, that colon cancer that ultimately took his life probably started in his 20s. And as far as screening, unless there's a 1st-degree relative that has colon cancer, nobody's going to start to look for colon cancer in anyone in their 20s. So his case might be an outline case. But for the rest of us, these are the things I want you to know. I'm just going to cut to the quick here and tell you some, straight up, like, no frills, no extra packaging. This is what you need to know. And as always, we are not diagnosing or treating on this show. We are providing educational information, and you need to go and have this conversation with your primary care specialist. That's your gateway, that's your beginning. And then if you need to be referred to the specialty that usually takes care of colon cancers, which is gastroenterology, you will be referred from that point. Got that? You're going to get your primary care doctor. You're going to have your conversation with your doctors. And we're just going to give you some education here, kind of the heads up of what's up. And the information that I'm getting is coming from the American College of Gastroenterology. So just as the information that Dr. Dietrich shared and Dr. Khadija shared, it was evidence-based, and this is also evidence-based. So according to the American College of Gastroenterology, all y'all out there that are 50 years old, you hear me? 50, you should have your baseline colonoscopy. Now, Dr. Dietrich just told you what the colonoscopy was. You should have that. That is the gold standard. And one thing that's so beautiful about it, it is both diagnostic and curative. If they find a little polyp, that's just a little baby polyp. It's not cancerous now. It's not going to hurt you right now. They take it out before it gets the chance to grow up and be a big, bad cancerous polyp. Straight up, bottom line, plain and simple. And every day in my role as a primary care doctor, I will ask that question, have you had your baseline colonoscopy? Oh no. And there's 1,000 excuses and reasons why not. All kinds of, oh, I don't like the prep. I understand the prep is terrible. Men that make comments that are, homophobic and all. And I was like, what do you think your level of invasion is going to be if you get colon cancer. So if you can't deal with a colonoscopy, which you are put to sleep, it's kind of a twilight sleep, over very, very, very quickly, little to no after effects, complications. It's handled by the experts. The gastroenterologists are the experts. I love it. A colonoscopy beats a colostomy bag. Yes, it does. And tragically, I had a patient who every year we'd have the conversation. Every year he declined. Every year documented in the chart, declining against medical advice, here are the pros, here are the cons. Oh, I just feel some kind of way about somebody touching me there. This man, unfortunately, lived to regret those words because he did develop a colon cancer. And he said, Doc, I wish I had listened, because what has gone on now in my body.
I can't agree with you more. I had the same experience.
And I love this man. I love Victoria was saying she had a PCP that made her get her colonoscopy. And, this was such a great guy. And to watch him suffer needlessly when he could have gone ahead and had the colonoscopy. So that's the gold standard. I don't want to miss that. There are some other options, but this is what you really want to take advantage of this. And when you are 50, now, when do you need a colonoscopy? Prior than age 50. It is recommended that if you have a first-degree relative that develops colon cancer before the age of 50, so let's say they were diagnosed at 45, you would get your first colonoscopy 10 years prior to that. So you would get it at age 35. Got it? So if you have a first degree relative that gets colon cancer before the age of 50, so that's your mother, your father, your grandparents, a sibling, aunt or an uncle, then you get yours 10 years prior to that. Remember, colon cancer tends to be a very slow growing. Good evening, Sandy.
Hi.
It tends to be a very, very slow growing cancer. All right, so that is, that's what you need to know. However, there are some challenges to that. Colonoscopy is expensive. There are some economic limitations. If you don't have certain insurances, kind of insurance, a certain level of insurance, it might be less accessible to you. However, there are programs and there are ways of going about it. It is worth fighting for. This is a test you want to fight to have. All right, now an alternate might be a flexible sigmoid scopy, and you can get that every 5 to 10 years. Now, colonoscopy looks at the whole area. The sigmoid oscopy only looks at a part of the colon, the part that's closer to the anus. It doesn't go around all the bends and turns. So it's possible that it could miss a cancer. However, it is available every 5 to 10 years. Okay? Then you can also get a colonography, which is a CT scan of the colon. You can get that every 5 years. Or you could get the fecal immunochemical test or FIT test that's looking for those occult or hidden blood in the stool. You can get that yearly. If that comes back positive, they do find blood, the recommendation is colonoscopy. But as long as it keeps coming back negative, you could just keep getting that year to year. Yes, is it possible that can miss a cancer? Absolutely. Absolutely. So your gold standard is your colonoscopy. And what I'm really trying to do is encourage people not to be afraid of it, to think through it logically. My goodness. So you're going to get cleaned out with the prep, and the prep is getting better and better. So it's less harsh. So they want the colon clean so they can see everywhere in it and thoroughly. And just think about it. If you were doing anything major in your life, you want to go to that expert that's going to just go to every little nuance, every little corner, and make sure that whatever the thing is, it is correct. And that's what your gastroenterologist is doing with your colonoscopy. It is the test that you want to have. And you want to have your baseline at age 50. And guess what? If it comes back negative, you don't have to have it again for 10 years. That's how comprehensive it is. And that's when we look at the randomized controlled trials, shows you how good a standard it is for finding those early cancers. So that means no more till 60. If they do find polyps and they remove the polyps, depending upon the number and the size, they're going to say you need to come back and have the test repeated in 3 to 5 years. Okay? It saves your life. It saves mortality and morbidity. So the colostomy bag is actually a bag that's put outside of your body where it collects your stool or your fecal matter outside of the body. Oftentimes, this is something that could be reversed, but really, you want to deal with that? That has to be changed every day, emptied every day. You're handling your own fecal matter. Most people don't like to touch their own fecal matter. Most people, just think, this is something you have to wear, shirts that kind of fit over it. Otherwise, it's something that's visible and can be seen. So you really do want to be on the side of the colonoscopy. I am a hero or a champion for the colonoscopy, and you'll be grateful that you did it. All right, so those are the screening tests. That's the gold standard, starting with the gold standard recommended by the American College of Gastroenterology. Okay. Let's look at, I'm going to go to treatment and then I'm going to go to prevention, because Dr. Dietrich actually mentioned a lot in terms of prevention. But again, this is something that you can do. You can prevent. You can increase the likelihood that you're not going to get colon cancer in the first place with very few simple lifestyle choices. Okay? And I love talking about lifestyle choices. All right, so here we go. Because I love prevention. An ounce of prevention is worth a pound of cure. So treatment. There are 4 stages of colon cancer. So depending upon what stage you're diagnosed in, that is going to depend upon the treatment. And the treatments get more invasive the higher the stage. So carcinoma in situ or stage 0, least amount of invasive treatments all the way up to stage 4, which has the most amount. And there are basically 7 types of treatment. So number 1 is surgery, and that can be local, where they actually cut out the polyp or just a piece. Or it can be a resection where they have to cut out, 2 ends of the colon and then try to anastomose it or put it back together. And that's often where you're going to have that external colostomy bag placed to the outside. That may or may not be reversible depending upon the condition of your bowel. Number 2, radiofrequency ablation. Number 3, cryosurgery. Number 4, chemotherapy. Number 5, radiation therapy. Number 6, targeted therapies. Again, depending upon the specific type of colon cancer that you have, and they determine that by taking tissue biopsy. And number 7, the new immunomodulation therapies, where they really look at the genetic aspect of the tumor and the tissue type, and they use the immunomodulation medicines because they treat it like it is an immune system disorder. All right, so thank you. Those are the 7 different approaches. And again, this is all from the American College of Gastroenterology. So, and it's good information for you to know, because a lot of people, you get gripped by fear when you hear a diagnosis of colon cancer. And so take some notes, put these away. You want to take this with you when you go to see your doctor, so you can have the conversation calmly. Or if you get the diagnosis, you can then go back and see, okay, there are treatment approaches here. Not one, not two, but there are 7. So we do have options, and people are treated, and people do survive. All right, so again, that's the surgery, the radiofrequency ablation, the cryosurgery, the chemotherapy, radiation, target therapy, immunomodulation therapy. And then also something to think about, clinical trials. They're making advances in colon cancer treatment all the time. So you might want to reach out to National Institute of Health or the Center for Disease Control and see what clinical trials are available. And you might find that you're an excellent candidate for the clinical trials. And in those cases, if you're accepted, your treatments, your surgeries, whatever it is that you need is all paid for. Okay, guys, prevention, and then we're going to wrap it up. Lifestyle modification. We do something in America called SAD, and that's how we eat. The standard American diet is a risk factor for colon cancer. We eat processed foods. Stop eating processed foods. If you can't pronounce it, don't eat it. If it doesn't rot, don't eat it. It's just straight up, just real straight talk. If it lives on a shelf indeterminately, it's not food. We put it in our mouth and we put it in our body, but it's not food, it's chemicals. And you have to understand that. So you want to eat foods that have high fiber content. So these are your dark leafy green vegetables. These are your fruits. Do you all realize this is your broccoli, this is your cauliflower? We're in this country, we're so funny. There's at least easily 60 variety of fruits and vegetables, yet most of us only eat like 2 or 3. What's up with that? Walk around the perimeter of your grocery store where they have the fresh fruits, things that rot. That's what you want to eat. You want to eat, if it rots, you want to eat that. And look at jackfruit. How many of you eat jackfruit? How many of you know what jackfruit is? So I'm going to challenge everybody this week to eat 2 things that are identified as vegetables that are in the fresh food section of your grocery store, the fresh produce that you've never eaten before. And then go ahead and look it up, and you'll find that it's rich in antioxidants, that it's high in fiber, that it has all kinds of properties that are excellent, that are good for you, that'll make your skin better, that'll clean out your bowel, all these kinds of things. So challenge yourself to eat something other than the 2 vegetables that you normally do eat. Find some fruit that you normally don't eat. Try that. Expand your palate. People will say when I tell them, okay, you need to cut out processed foods, you need to cut out dairy, you need to cut out most meat products. A small amount of meat. Meat should be like the smaller thing on your plate as opposed to the larger portion on your plate. And they say, well, what will I eat? I don't know what can I eat? And I said, well, let me tell you. And then I'll hand them a list of 60 fruits and vegetables. I said, well, look at all this. These are all edible things. How many of these things? No, I've never tried that. I don't know what that is. I said, well, you just asked me, what can I eat? And I just gave you 60 more things you could eat. And this is what will save your life. This is what you have control over. So you need to educate yourself. If you're not sure, you can certainly work with a nutritionist. You can certainly begin to look things up. I would say talk to your doctor. Unfortunately, a lot of doctors are not trained in nutrition. It's a sad fact. It's a deficit in our in our medical school education. But you can find doctors who have taken additional training, so we really do know what nutrition is about. So question, what about whole grains? You got to be careful with whole grains. Got to, again, you want to eat those in limited amounts and small amounts. Whole grains are better than the polished grains. So white potatoes, no. White rice, no. White cereals, no. Most oatmeal, no, because it's processed. Steel cut oatmeal is okay. But that stuff that you buy in the box with the man with the funny hat, processed, got a lot of sugar in it. And even though it says it lowers cholesterol, you got to start to read the ingredients. If one of the first 3 to 4 ingredients is sugar, put it back, because you want to eliminate processed sugars. And also, most grains in this country that are grown and produced in this country are GMO modified. You don't want those. They got like mouse parts in them and corn in them. That's how they're modified, to make the crops hardier and make them grow taller and bigger. So, so corn is a no-no. Most wheat is a no-no. Some ancient grains are okay. Some spelt is okay. But again, you really need to understand how it's grown, because just as we are what we eat, well, what our food eats is what the food is. So if it's grown in depleted soils, it is also nutritionally deficient. Doesn't have the fiber content that you need. So you're really better off with mostly a plant-based diet with again, minimally processed meat. So you want things that don't have antibiotics in them. You want meat that is free range. You want meat that's been certified organic. A little bit more expensive, but you actually eat a lot less of it. So meat is more of a condiment as opposed to the main part of the meal. Yes, free range, certified, organic. Absolutely. Absolutely. So, and then again, Dr. Dietrich did mention, cutting out the alcohol, stopping smoking, exercise, doing things like incorporating meditation in your life, because meditation starts to turn on the body's own hormones and chemicals that are good for you, that are healthy, that are healing, that also help to heal the gut. And this is what you want, to have a well-balanced gut. And you also might work with someone who knows about things like probiotics, so that your gut then has enough of the good bacteria in it, again, which is also cancer preventing. What about basmati Indian rice? A little bit of that can be okay, but you got to be careful with rice, because rice is what? It turns to sugar in our system. So you have to be very, very careful with rice. Probably the safest and healthiest rice is either black rice or red rice. No polished rices, though. No white rices for sure. And probably not most brown rices. Healthiest rice is going to be your black rice or your red rice. All right. So that's, the prevention. And yes, exercise. So find the movement that works for you. Yoga's great. There's actually a whole series of abdominal exercises that you learn in yoga that are designed to help you with colon health. But you know what? Get out and walk, y'all. Walking is a full body exercise. Wow. Get out and swim. That's a full body exercise. And these exercises are good for our guts. And these are all standards of prevention. And prevention is, an ounce of prevention is worth the pound of cure. So I hope these tips have been
I did see a question.
Oh, it was another question.
It was very helpful. I just wanted to make sure we didn't miss any of the questions. And there was one question, I believe, by Dr. Ken, about could we talk about mention some of the complications using the scopes or the colonoscopy. Um, I just know that there could possibly be a reaction to some of the anesthesia, um, bleeding. Sometimes you might have what's called a perforated intestine, meaning that the instrument might actually puncture the inside of the intestine. This is very rare. Um, and then also infection. And with the older folks, there's a little bit of a risk, possibly because of dehydration. You got to have that clean out the night before, and so uh, some of the older folks may not tolerate that as well as far as from a hydration perspective. So those are some of the common uh, complications that can happen with that, but it still shouldn't dissuade you from getting it done. Because I mean, exactly what Dr. Carroll was saying too. I have many patients who I bring it up every year and they always have some type of reason. And, for exactly what she was saying. But, if you think about it, if you had a clean colonoscopy, you don't have to get it done for 10 more years. I mean, 10 years, that's a long time where you can just knock it out right now. So, those are some of the complications that could possibly
There
happen.
was a question in the chat about probiotics and what's a good probiotic. So a good probiotic is going to have multiple strains in it. So there's a number of very good probiotics out there. So one, you want to look for the probiotics that are kept in the refrigerator section, because they're going to have live multiple strains. And so you want the probiotics that have the live cultures in them, and you want the ones that have multiple strains and like a high amount, like 60 billion in there, because our guts are very, very complex, and there's this whole colony of bacteria that lives in the gut. The gut is 80% of our immune system, and probiotics can definitely help boost the gut and boost the gut's ability to be the excellent immune system that it is. So the multi-strain probiotics that are in the refrigerator section. There are some that are on the shelf that are stable, but again, become a good label reader, so because it will identify it as stable or not stable, but be on the safe side and get the ones that are in the refrigerator section.
Great.
Okay, guys, so we've had a really great discussion, and we're coming up on an hour now. That was really good. Thank you guys so much for engaging us and just realizing how important this is to all of us. And we can look at this discussion as a parting gift from Mr. Boseman. Because I know he would want us all to learn from this. And we thank you so much for joining us tonight. Do put in the comments other topics that you would like us to discuss. September is a big health awareness month, major health awareness month. So just to help us choose future topics, definitely put what you would like to know about or discuss with us in the chat. And before we sign off, we'll just say who we are once more. Let's see, starting from Dr. Dietrich on your end.
I just wanted to say a final parting thought to kind of sum up, like what Dr. Carroll was saying, prevention. Don't get to the point where you have to chase a disease. So try and prevent it, and you can prevent a lot of things through your diet. And I'm definitely becoming more aware of that. So prevention. And then know your family history if at all possible. Know if you're going to need to get your screenings earlier than the recommended time. Okay. So thank you for joining us. Please join us for another episode. I'm Dr. Dietrich Gorman. I'm America's Relaxation Doctor, best-selling author, speaker, and consultant. And thank y'all for joining us.
Dr. Carol.
Thank you, Dr. Dietrich and Dr. Khadijah. I'm Dr. Carol Penn, doubly board certified family medicine and obesity medicine, and also a master movement meditation and mindset coach. This is a very, very, very important topic, and it's in your hands. You have the power to do something about this. You don't have to wait to get to your doctors to be told. Educate yourself. Education is going to be your best friend in terms of prevention. Get your hands on everything that you can read. Ask questions. Demand that of your healthcare professionals, that you want us to educate you. So when you go to your primary care doctor, have your questions written out,
Yeah.
learn about all your organ systems, but especially learn about your gut and learn about your colon. This is so fundamentally basic to your health, your well-being, your mortality and your morbidity, and the quality of your life. Because if you get a disease, quality of your life suffers. And I know Dr. Khadijah wants this and Dr. Dietrich wants this. We want you to live your best life so you can do what? So you can walk in your purpose and so that you can be the change that you want to see in the world. And together we'll make this world a better place. And we can only do that if you're informed and if you're healthy.
Yeah.
Thank you, Dr. Carol. And yeah, I couldn't say any of that any better myself. So I'll just say that, I'm Dr. Khadijah, your board certified emergency medicine physician and author of the book, Help Us Help You in the Emergency Room. And part of helping us help you is leaning more towards prevention instead of cure. Now that you know about the screening that Dr. Carol talked about, now that you know about the risk factors that Dr. Dietrich talked about, let's all focus on not becoming a statistic and, and staying out of the ER for symptoms like this. And on behalf of Perspectives in Primary Care, we thank you so much for joining us. And until next time, be safe, be well.
Bye.
Bye.
Thank you.
Thank you.